So, good morning, friends. Welcome back to Saturday Club meeting. And today we have repeat performance by Dr. Kiran Shah. Couple of weeks back, he had presented a synopsis of Epicon 22. And now today he'll be presenting part 2 of the same because some of the topics were left out because of lack of time. So introduce Dr. Kiran Shah again. He's a senior consultant physician of Baroda and has 3 decades of experience with him. He's director of Spandan Multi-Speciality Hospital, and he had several presentations at national and international conferences to his credit. And he has been very integral part of Saturday Club of Baroda. So welcome, Dr. Kiran Shah. You can start your presentation for about 40 minutes. And
Thank you, Satish Bhai. Thank you, Satish Bhai, for your kind words of introduction. I think I do not require any such type of introduction reported repeatedly. Okay. Anyway, so, okay. I'm sharing my screen.
Yeah,
Good morning to everyone. Okay.
Yeah, Kiran bhai, it is visible.
Yes. Good morning, everyone, respected seniors and colleagues and friends. Last time, 2 weeks back, we had presented Epicon Update 2022 Part 1. And now I'm going to present today about the Part 2 because some of the topics are important. Some of the topics has been left at that time because of the lack of time. And I think it is not possible to cover each and every aspect. So I'm only covering which are I had attended, as well as some of the important topics which I think so. So it is Epicon 2022. It was held in from 14th to 17th April 2022 in Jaipur, Rajasthan. And it was held after 2 years of lapse because of the corona pandemic. It was not conducted, and this was the first after corona pandemic in virtual physical form. It was held in Jaipur Exhibition and Convention Center. Those who has not attended last time, it is held in Jaipur Exhibition and Convention Center, which is located 10 kilometers from the Jaipur main station. As you already know, it is one of the largest pillarless exhibition convention center facility. It's in South Asia. It's a multi-purpose spaces having good halls, and it occupies nearly 16,000 guests at a time, which are having a very good rooms and everything, not repeating everything. Okay. So straight away, I am coming to our topic. That is the theme of the conference was cutting edge science in medicine. Which means all the new things, what exactly is happening in the 2021 and 22 has already been incorporated in this conference. So something about Epicon. Epicon historically is one of the biggest scientific conclave for physicians of India, also biggest in the field of healthcare. API, that is Association of Physicians of India, was established in 1944. This was the 77th annual conference of the Association of Physicians of India. The scientific programs include lectures, orations, debates, panel discussions, case-based presentations, workshops, research papers, poster presentation, and things. And there were a lot of entertainment and other activities also, which I am not going to take this time. So in our last talk, there were some questions and something were raised about the nutritional aspect. So this time I am taking the nutrition part, that is nutrition corner. So whatever important discussion has taken place in this nutrition corner, I am going to take this time. First part. So there was a very good lecture by keynote address by the Dr. Sasank Joshi. You already know he is a very eminent diabetologist and endocrinologist from Lilavati Hospital, Mumbai. He is also a Padma Shri awardee. He has taken the topic that is chrononutrition, a new dietary dimension. You already know that chrononutrition is an emerging concept. It's a emerging field of nutrition science that aims to develop understanding of meal timings and its impact on health. Till now, we are discussing that it is only the frequency and quality of food that is related with the diabetic, but it is not so for all metabolic disorders. The meal timing is also an important, and its impact on health is also there. What we currently know is that factors like meal times, energy distribution throughout the day, nocturnal eating, and number of food episodes influence the health and imbalance in nutrient metabolism that leads to metabolic and nutritional disease. In people who are shift workers, there is a phenomenon which I called, means Dr. Sasank called that it is a social jet lag during COVID, where there is a serious circadian cycle malalignment leading to cardiovascular, neurological, mental disorder, and metabolic syndrome that we had already seen in couple of last month or year. So those who are having a sick worker, there is a definitely misalignment of the circadian cycle, and that definitely impacts the cardiovascular, neurological, mental disorder, and metabolic syndrome causes. The chrononutrition encompasses 3 dimensions of the eating behavior. That is, first is the regularity, second thing is the timing, and third is the frequency. So all this chrononutrition includes regularity, timing, and frequency of meal, with the focus on influence on energy expenditure and body weight. So particularly these factors, that is regularity, timing, and frequency, definitely has focus on energy expenditure and body weight. The ADA recommends that, that is American Diabetic Association recommends that for weight management, the total calorie intake should be distributed in 4 to 5 meals. That is, in 2021, they have clearly given a statement that it should be distributed over 4 to 5 meals. That includes breakfast, which may be more a better strategy than the concentration of consumption of meals to prevent weight gain and related disease. So rather than giving a single meal, so if someone is telling you that I am taking only 1 meal, so it is not a good, it may be the cause of weight gain rather than weight loss. So the ADA recommends that meals should be distributed in 4 to 5 frequency. The recent advances has linked the circadian timing system to metabolic physiology and nutrition, comprising a relatively new era of evolving interest. Increasing meal frequency includes weight loss and improves metabolic parameters like fasting blood glucose, insulin, cholesterol, and triglycerides, thus reducing the risk of developing type 2 diabetes mellitus and cardiovascular disease. So that timing is a very usefulness of this circadian timing system or rhythmicity is a very important in improving the metabolic parameters like fasting blood glucose, insulin, cholesterol, and triglyceride, and thereby it has definitely impact on type 2 diabetes mellitus, cardiovascular disease, and metabolic disorders. It is also important to understand diabetes specific nutrition. So skipping a 1 meal and incorporating this diabetic specific nutrition, slowly digested carbohydrates travel further down the small intestines, where a higher density of L cells are found, and hence stimulates a rise in GLP-1. That everyone knows that GLP-1 is now a well-established factor in glycemic or glucose metabolism. Morning energy intake may have substantial health benefits. Feeding time helps to decide on the expected benefits with specific nutrition. So specific nutrition and feeding time, that is a very important two factors. Partial meal replacement with diabetic specific nutrition is one strategy to help obese diabetics to lose body weight. So particularly in diabetic, those who are obese, if you do a partial meal replacement with diabetic specific nutrition, supplementation, it is one of the strategies to lose the weight. So it is a very important, you all know. So ultimately what Dr. Sasank Joshi has told at the end that he has given a prevention mantra. Eat less, eat on time, eat in morning, eat slowly, eat right, walk more, sleep well, and on time, and smile. That is what the prevention mantra he has given. It was a very good lecture, no doubt. And it has opened up a very good discussion as well as the science, particularly in the core nutrition segment. There was one another important side-by-side lecture going in the same, incorporating this circadian rhythm in metabolic disease by Dr. Verma. And the circadian rhythmicity is also very important, as you already know. Circadian clock regulates metabolism and energy homeostasis in peripheral tissue by mediating the activity of certain metabolic enzymes like phosphorylase, fatty acids, synthesis, etc., and transport system involved in cholesterol metabolism, amino acid regulations, glycogen, and glucose metabolism. So circadian rhythmicity has very definite important aspect in doing certain metabolic enzymes regulations also. The effect of metabolism on the master or peripheral clock could rise from feeding, food metabolites, or hormones whose secretion is controlled by food or its absence. Circadian clock regulates levels of neurohormones involved in cardiovascular functions such as angiotensin 1, renin-aldosterone system, growth hormone, and atrial nucleic peptide that you already know. Circadian rhythm is a natural way to protect body from metabolic overturns. It operates through genetic, epigenetic, enzymatic, and hormonal regulations. Desynchronization of circadian rhythm is most important cause of all metabolic disease. Desynchronization can alter the fate and pace of the metabolic disease. And circadian rhythm syndrome includes metabolic syndrome as well and other related disorders. So there is a circadian rhythmicity is also a very, very important aspect in dealing with the metabolic disease or lifestyle related diseases. There was a oration lecture, actually, Rabindranath Tagore oration lecture, and by a very eminent gastroenterologist, Dr. Gurdas Chaudhary from Jaipur. And the title was Intermittent Fasting as Therapy for Lifestyle and Metabolic Disorders, Lessons from Blue Zones. So he has actually given a very important, you already know that there were various diabetic patterns or diabetic diet regimens, that is, and one of them is intermittent fasting as therapy for lifestyle and metabolic disorder lesions from blue zones. I will give some more details what is exactly these metabolic disorder lesions and what is exactly the blue zones and intermittent fastings. He has given us a very good idea about the different dietary regimens that includes change in food type and quality. Like means dietary patterns includes change in different types of foods, timing, quality, and like that. So if you change the quality, that is like Atkins diets, keto diets, and another important thing is the time restricted diets. So not only the quality of food, but the time restricted pattern is also an important, that is what we have seen, that is in chrononutrition. The time restricted diet that includes intermittent fasting also. So this intermittent fasting encompasses two important aspects. That is a short eating window and a long periods of calorie restriction. Means it encompasses from 8 hours fasting eating and 16 hours fasting in a 24-hour. Or it encompasses like this, 2 days of fasting and 5 days of eating in a week. Or it may be alternate day like that. So there are various patterns of these intermittent fastings that has already been included. So there is a short eating window and a long periods of calorie restriction. That is the main aim of this intermittent fasting. This early time restricted feeding, that is ETRF, improves cardiometabolic health. It produces metabolic switch. What is that metabolic switch? Is that liver-based glucose burning to adipose tissue-based ketone burning. So what is exactly is in our bodies routinely is the liver-based glucose burning. And if you change it to adipose tissue-based ketone burning, it is considered as the metabolic switch for fuel or energy consumption in our body. It decreases carbohydrate metabolism and increases fat plus ketone metabolism. That is what is the main aim of this intermittent fasting. Some of the important thing about this This is exactly what metabolic switch he has told us in that talk. That is liver-based glucose burning to adipose tissue-based ketone burning for fuel production. And effect of this intermittent fasting on metabolism, that you already can see that there is a decrease in carbohydrate metabolism and there is increase in fat and calorie metabolism at the end of 5 to 10 days after this incorporation of this intermittent fasting. So again, what exactly the blue zones? We had seen that it is intermittent fasting, and what exactly the blue zones? Blue zones are the geographical areas in the world where people live longer than the rest of the world. So there were hundreds or thousands of centurions people are there in this particular area. And the caloric restriction and periodic fastings are common in blue zones. Means blue zones are the areas in or geographical areas in the world where people live longer compared to the rest of the world. And two most common important thing what has been noticed in this particular area because of while surveying this area is that there is a calorie restriction and periodic fastings. These blue zones includes like some of the Icaria of Greece, Sardinia from Italy, Okinawa in Japan, Loma Linda in California, USA, and Nicoya in Costa Rica. These are some of the blue zones which I have given you just for example. Here, this Dan Butner has done a geographical survey and he has published a good study in the blue zone solution named like a blue zone solutions. He has started this particular study in 2014 and completed in somewhere in 2019 and published a very good paper in 2021. And he found that the most common practice is that is a periodic fasting because of some religious or thing like or something like there is a common pattern what they have found in these particular regions, along with fasting and that is calorie restriction and fasting gives them a very good health pattern and thereby they are living a longer compared to the rest of the zones. So in summary, calorie restriction and periodic fasting are common in blue zones, and both these practices can significantly reduce risk factors for certain diseases and prolong healthy life. So this is one of the very important thing what has been found in this particular nutrition segment. Coming to the next topic, that is our ischemic heart disease and coronary artery disease. Managing heart attacks, Glasgow practical approach. There was a very good lecture by Dr. Henny Itiba. He was from Sweden, and he has given us a very good topic and very good idea about what exactly the practical approach in Glasgow. Some of the important things. Ischemic heart disease remains the #1 killer in India. You already know. Acute coronary syndrome that ranges from unstable angina, non-ST segment elevation myocardial infarction, that is NSTEMI, and ST segment elevation, that is STEMI, reflecting a continuum of severity of coronary stenosis. The main important of this thing is that structure for all of these is whether acute coronary syndrome, whether it is unstable angina, ST segment elevation MI, or non-ST segment elevation is the vulnerable plug. What is vulnerable plug? Angiographic studies have indicated that in many cases, medium-sized plaques, that is comprised of nearly 30 to 40% of the stenosis, are more likely to rupture than larger or more obstructive ones. Means the degree of stenosis is not important, but it is the size of the plaque which is more important. And the vulnerability is more important rather than total stenosis or like that. Moderate plaque may be vulnerable, but because they are less mature. Why these vulnerable plaques are more important and medium-sized vulnerable plaques are more important? Because they are less mature with a large lipid core and a thin cap prone to rupture or erode, exposing the thrombogenic subendothelial component. So it is medium-sized vulnerable plaques which are more important rather than stenosis, degree of stenosis. He has in his Glasgow area, He level 10 told us, although one primary PCI is clearly superior to thrombosis when looked at establishing our primary PCI services in Glasgow, it was obvious that it is not practical or feasible to offer one PCI to entire population. So if you find do angiography and found that there is a 30 to 40% or like that stenosis, so it is not possible to offer primary PCI in each and every one. Finally, the strategy of delivering one PCI as one-stop complete revascularization or time differing stenting PCI for STEMI is the preferred strategy when can be timely delivered. So when it is a vulnerable, only then and then you offer such type of services. So the primary PCI is considered the treatment of choice when facilities with high volume, experienced operator and team are ready, available for STEMI patients who can be promptly transferred. Means those patients who can be readily transferred where there is available such type of things are, and when there is a large volume, then only it is possible to give a primary PCI to such type of group. And now the emerging concept is that reduced intracoronary thrombolytic therapy is an emerging concept currently being explored in T-time randomized trial. Massive intracoronary thrombus in STEMI patients increase the risk of distal embolization, no reflow, LV dysfunction, and mortality. So in such type of patient, it is not feasible to give or immediately revascularize. Pre-hospital optimum double antiplatelet agent, anticoagulants, and prompt transfer are important measures to minimize the thrombotic burden in such type of patients only. Although there is no ideal pharmacomechanical management strategy, a treatment plan should be tailored to individual patients who may benefit from specific therapy. So main aim is that it is not possible to offer primary PCI to each and every patient, and you have to have a practical approach. So that is the main thing what he wants to convey. The same thing has also been told by our own senior colleague, that is Dr. Manutos Panja from Kolkata. He is an interventional cardiologist. He has also told that the current optimal management of chronic coronary syndrome. You already know that chronic coronary syndrome is not stable, silent, and not always suddenly develop acute coronary syndrome. 90% of the patient had chronic coronary syndrome among ischemic disease. The basic management of non-pharmacologic and pharmacologic therapy should be followed in such type of patients. Improvement of lifestyle, use of cognitive behavior techniques, and exercise-based cardiac rehabilitation are important aspects in non-pharmacological management. In patients with new onset heart failure or reduced LV function, diuretic therapy is recommended in symptomatic patients with pulmonary and systemic congestion to relieve heart failure symptoms. Beta blockers are effective and essential in relieving angina. And AC inhibitors are recommended in patients with symptomatic heart failure or asymptomatic LV dysfunction following myocardial infarction. So he has clearly told that along with non-pharmacological therapy, pharmacological therapy like beta blockers, AC inhibitors, and diuretics are considered a major important aspect in the management of coronary syndromes. In spite of judicious guideline-directed medical therapy, the result of medical therapy alone is comparable and showed a similar identical outcome of chronic coronary syndrome as compared to medical therapy plus coronary intervention. So in this particular group of our cohort patient, he has clearly told that rather than giving us interventional therapy, if you give good, very good or ideal medical therapy, it is equally important, equally effective. So you need not to worry about that. And there is a definite comparison between this interventional and in only medical guided therapy. So these are very important things for us to know. Now coming to the infectious disease segment. In this, there was a presidential oration. Though this particular disease, that is a Kala Azar, is not common in our western parts of the country, it is very, very common in the eastern part of the country. And that is a very, very important disease, that is Kala Azar. Indian Kala Azar from 1 month to single dose treatment. And this presidential oration lecture was taken by Dr. Shyam Sundar. He is the president of API also from Varanasi, Banaras Hindu University. In this particular, very briefly, I will tell you that Indian Kala Azar from 1 month to single dose. We already know that Kala Azar is a serious medical and public health problem. And Indian National Expert Committee has established this particular therapy process. And it has already been recognized by the World Health Organization also. And they told that use of amphotericin deoxycholate as first-line agent in areas with more than 10% of the unresponsiveness compared to amphotericin B deoxycholate, miltefosine has great oral advantage, easy to implement in the program, 28 days regimen. So if you want to give a long therapy and if you want to use this amphotericin B, it gives a very good result as well or comparable result. So that is what is the main thing. And if you don't want to give this single dose amphotericin B, another important molecule is the miltefosine that you can give orally for 28 days. This is particularly very important. And another important molecule also they had found out that it is a paramomycin, is a safe, affordable, and effective drug for the treatment of visceral leishmaniasis. During last 2 decades, significant change occurred in the treatment of Kala Azar that you already know. Because we are not seeing such type of Kala Azar, we are neglecting this, but it is very important disease in Southeast Asia. In India, single dose, that is Lambison B, become the treatment of choice, and its use in Kala Azar elimination program has helped in achieving the goal. That is the main thing, and it has reduced lot of burden on the health sector also. And multi-drug treatment have shortened the duration of treatment also. Also, who has recommended treatment regimens for visceral leishmaniasis? That is what is the important things which came from his lecture, that is Indian Kala Azar from 1 month to single dose treatment regimen. Another important disease which I have attended, a lecture I have attended and it was discussed, is the hepatitis B virus management in 2022 by Dr. Sandeep Nizwan. He was also from Jaipur. The main crux of this lecture was that hepatitis B virus infection is a global public health problem with overall prevalence around 3.5%, and in India it is somewhere around 2 to 7%. Dr. Sandeep Nizwan from Jaipur has very nicely presented how to manage hepatitis B virus infection in 2022 in different situations with clear-cut algorithm. And he has also very nicely given the importance of HBe antigen along with surface antigen and its relative infectivity of HBsAg carriers also. Some of the important slides which I have captured during this lecture is this. These are the phases of chronic HBV infection that you already know, that is immune tolerant, immune clearance, that is HBsAg positive, chronic hepatitis, infective carrier state, and reactivation HB hepatitis negative but chronic hepatitis. These are the 4 main phases of this chronic hepatitis B virus infection. He has also told about the serology in acute hepatitis B, that when at what time these serological markers are important in dealing with the hepatitis B. And based on this particular thing, he has given us a very good algorithm-based approach. So whenever you find that there is a surface antigen, that is HBsAg positive patient is there, what you should do next thing is you do the HBe antigen. If it is positive, then what to do? And if it is negative, then what to do? If HBe antigen is positive, then next thing what you have to do is the SGPT estimation. And 4th thing what you have to do is the viral load estimation. And if you do all these 3 things, that is Australia antigen, HBsAg antigen, HBe antigen, SGPT, and HBV viral load, then you are able to give whether this patient requires treatment or not required. That algorithm-based approach, that is what is important. From this, if it is HBe antigen positive and SGPT less than 40, HBV DNA more than 20,000 unit, antiviral treatment is not required because it is not active. SGPT is less than 40. If SGPT is 40 to 80, then what to do, and if SGPT is more than 80, then what to, whether the treatment is required or not. That is very good algorithm based approach and very practical in implementing in our day-to-day clinical practice. This is what we have to do when HB antigen negative, SGPT less than 80, SGPT more than. This is a very good algorithm. Now he has also given some important thing what to do when there is a hepatitis B and pregnancy. Because we already know that it is associated with the transplacental spread. So it spreads from mother to fetus also. And the risk of transmission is 10 to 30% in hepatitis B antigen positive and 5 to 10% in hepatitis B antigen negative mother. And high viral load is associated with the increased chances of infection to infant. And in such type of what to do when there is a pregnancy and hepatitis B is positive, we have to give the immunoprophylaxis, and vaccination reduces the risk to less than 1%. So it is very important in dealing with such type of situations. Again, he has also told how long to treat, whether the treatment is required for lifelong or not. If you are doing with the treatment and you found that there is HbA/AG becomes negative, yes, it's an indication for cessation of the therapy. Another important thing is that there is HB antigen seroconversion with undetectable DNA levels, difference of opinion among different authorities. So, well, it is a very clear that if you get the HbA/AG negative, it is an indication for cessation of the but if it is HbA/AG positive, then what to stop, when to stop, there is definitely a difference of opinion. And Dr. Sandeep Rizwan has clearly told that he recommends lifelong therapy. He has also told what to do when there is a post-exposure prophylaxis. Algorithm has also been given to us. That is also very important. You can remember also. I'm not going into the detail of this thing. Now coming to the diabetes corner. Some of the aspects we had left last time. In this diabetes corner, there was a very good lecture by the reversal Dr. V. Mohan. You already know that Dr. V. Mohan is the chairman of this V. Mohan Institute of Diabetology, Diabetic Center, which is already an recognized center of excellence by international diabetic federations. He has given us a very good lecture on this reversal of diabetes, what you should know. Because now we already know that diabetes is possible to have a reversal. Means it is possible to have a cure and treatable causes. But exactly what you should know, that is what I will tell you in next couple of slides. Reversal of diabetes, what you should know. But actually this reversal of diabetes is not officially labeled by ADA. ADA tells that rather than using the word reversal, you should use the word remission. ADA proposed remission as when the HbA1c is less than 6.5%, measured at least 3 months after cessation of glucose lowering pharmacotherapy. So if you found that HbA1c is less than 6.5% after 3 months of stopping the pharmacotherapy, then you can say that there is a remission and not the reversal. So correct word is not the reversal, but it is a remission. Diabetes remission can be achieved with the intake of very low caloric, low carbohydrate diets, intensive practical activity, appropriate stress reduction, early diagnosis, and aggressive treatment of type 2 diabetes mellitus at the initial stage only. These are the 4 most important things which will come to the later. Most importantly, re-reversal of the diabetes or relapse of diabetes occurs in large percentage of the people. So the AD has proposed that it is a remission and not the total reversal. Because in majority of the patient, when you say that it is complete cure or reverse, means after some of the times, what exact times and things had not been yet known, but there is a definitely re-relapse or re-reversal. That is what the terminology used by them. Conversion with people with type 2 diabetes targeted population should include discussing remissions. The dietary approach to achieve remission is less important. Low calorie diet and low carb diet can be equally effective. Programs supporting people towards achieving remission need to be structured and offered continuous, regular support, including the involvement of dietitians for long-term success. In many cases, re-reversal or relapse of diabetes occurs, but this is hardly emphasized. So I will tell you some of the very good slides which I captured during this particular lecture. This what you see is the natural history of diabetes. Right till now, so far we are going from left to right. That is normal glucose tolerance, normal glucose. Just pointer. Right now we are going from left to right in the natural history of diabetes. That is a primordial prevention, that is normal glucose, then primary prevention, then secondary prevention, and then tertiary prevention, means once there is a complications. We are going right now from left to right, but now we have started thinking or talking about this right to left. Now we are talking about from right to left. And that is a new focus, and that is what we are labeling it as a remission or reversal of the diabetes. And in this particular chapter, in 2010 October, that American Diabetes Association has proposed remission as the most appropriate descriptive term, and HbA1c less than 6.5 measured at least for 3 months after cessation of glucose lowering pharmacotherapy as the usual diagnostic criteria of this remission of the diabetes. What are the examples of these remissions or of this diabetes? Under which circumstance it is likely possible that after severe weight loss, if you achieve severe weight loss, yes, you can achieve the diabetic remission. Post-gestational diabetes, after bariatric surgery, yes, you can achieve this diabetic remission. Stress-induced diabetes, drug-induced diabetes, and after early and aggressive treatment of new onset type 2 diabetes with short course of insulin therapy. So under these particular circumstances, you can achieve the diabetes remission. And how to achieve diabetic remission? With the help of these 4 important aspects, that is very low calorie, low carbohydrate diet, intensive physical activity, stress reduction whenever possible, and early detection, aggressive management of type 2 diabetes at initial stage, particularly where they had labeled that is only in early decades of the first decades of the life. So this reversal of diabetes comprises that. Particularly important thing is that reversal is a misnomer. Rather, we should use it as a remission. That is the correct terminology. Early detection and aggressive treatment of type 2 diabetes at initial stages, along with stress reduction where appropriate, and very low calorie, low carbohydrate diet, intensive physical therapy are the mainstay in having a remission or achieving the remission. Otherwise, it is relatively progressive, requiring increasing numbers of oral hypoglycemic agent and eventually intense insulin. And the 50% of individuals require insulin therapy within 10 years. That is what is the diabetes natural history. So the key message from this reversal or remission of diabetes is that while giving a conversation with the people with type 2 diabetes should be included words remission and not the total reversion, because reversal ultimately means that it is a curable or treatable, which is not possible in this. Dietary approach to achieve remission is less important. Less calorie diet and low carb diet can be equally effective. Program supporting means here what is important, by restricting quantity, it is not important. Quality as well as timing and other factors are also important. Programs supporting people towards achieving remissions need to be structured and offered continued and regular support, including the involvement of dietitians and long-term success. So that is what is the key message in this very good lecture. Now coming to the geriatric corner. Here, a very good lecture was given by Dr. Chaturvedi, and the most important thing is that hypertension in elderly, that is what is the discuss. You already know that hypertension is a potent risk factor for cardiovascular disease in the elderly. Although increase in the treatment and control of blood pressure in older hypertensive adults have occurred over the past 2 decades, BP control rates remains suboptimal in the elderly people. Non-pharmacologic lifestyle measures should be encouraged in older adults for development of hypertension and as adjunctive therapy in those with hypertension. The high prevalence of both cardiovascular disease and non-cardiovascular disease comorbidities among the elderly dictates need to great vigilance to avoid treatment-related side effects also in elderly. The diuretics, AC inhibitors, angiotensin receptor blockers, calcium channel blockers, and BPAC blockers have all shown a benefit effect on cardiovascular outcomes in randomized trials among elderly cohorts. So you can use any group of the molecule in elderly, there is no harm. The choice of specific agent is detected by efficacy, tolerability, presence of specific comorbidities, and cost. Hypertension is a very highly prevalent in elderly patients. It is a major treatable risk factor for CV disease. Comorbidities with hypertension makes the management challenging. BP treatment has shown benefits at all ages, including more than 80 years group also. Most obvious benefit is reduced mortality, both cardiovascular and non-cardiovascular. Lifestyle modification is useful, even with the drug therapy. Patients should begin with the low drug doses and titrate drugs slowly. For those more than 80 years, 140 to 45 mg is the acceptable systolic blood pressure goal. I will tell you just 10 brief points what to remember in while managing hypertension in elderly. These are the hypertension in elderly 10 things you need to know. That is, there is first is that there is a dramatic increase in the hypertension prevalence with aging by age more than 70 years. The majority people have hypertension, that is very clearly. If you cross the age of 70, a majority of the people have some sort of hypertension. In older adults, hypertension is characterized by an elevated systolic blood pressure. That is also one of the important characteristics of hypertension in elderly, with normal or low diastolic blood pressure due to age-associated stiffening of the large arteries. Third most important thing is the hypertension is a potent risk factor for cardiovascular disease in the elderly. Fourth is the numerous randomized trials have shown substantial reduction in cardiovascular outcomes in cohorts of patients 60 to 70 years old with antihypertensive drug therapy, though the effect on all-cause mortality has been modest. Fifth important thing is that although increase in the treatment and control of blood pressure in older hypertensive adults have occurred over the past 2 decades, BP control rates remains suboptimal in elderly. So as for one study, they had clearly told that it is only hardly 10% of the people achieve optimal blood pressure goal. Sixth important point is the non-pharmacologic lifestyle measures should be encouraged in older people compared to in comparison with the pharmacologic therapies, or to prevent development of hypertension as an adjunctive therapy in those with hypertension. Seventh important point is that to initiate antihypertensive therapy has a threshold of 140 by 90 mg in person 65 to 75 years and threshold systolic blood pressure of 150 mg in people age more than 8 years is unreasonable. So in people with more than 80 years, 150 should be the target. Eighth important point is the diuretics of AC inhibitors, ARBs, CCBs, beta blockers have all shown a benefit on CV outcomes in randomized control trials, elderly cohort. Choice is detected by efficacy, tolerability, comorbidities, and cost. The ninth important point is the initiation of antihypertensive drugs in the elderly should be generally be at the lower dose with gradual increment as tolerable. Means you have to start slow and go slow. The high prevalence of both cardiovascular and non-cardiovascular comorbidities among the elderly indicates need to great vigilance to avoid treatment, particularly while you are using with the diuretics in such type of populations. And you have to also closely vigilant about the related side effects. That is what is the main important 10 points while we're managing the hypertension in elderly. That is very important lecture in this geriatric corner. I think this is all what we supposed to know, or we can talk in this particular 40 minutes talk. Thank you for your patience hearing. Satish bhai.
Yes, yes. Thank you, Dr. Kiran bhai. Thank you so much for, again, a very comprehensive summary of what you have learned. And
Yes.
Saturday Club is meant for that only, learning and sharing. And you have said it so beautifully. I'm sure there are some questions. You can stop sharing the screen so that we can see.
Yes. Okay.
Yeah. I'm sure there are questions amongst the audience, especially regarding two paradoxical or opposite presentations. One was on having regular meals and other having intermittent fasting. So
Yes.
you can please explain that two theories and which is good for whom.
This intermittent fasting thing has been based on what they had observation in blue zones. Blue zones means, I had already told you that it is what is the geographical area where the people live. So only on that particular we have established that intermittent fasting is more important. Whereas the scientifically it has already been established that circadian rhythm and timing is very important, and that has already been established. So combination of these two things, I think it is the most important thing we have to deal with. Okay, rather than dealing with or dealing with only one thing, because we already know that there are definite disadvantages and advantages of one regimen. Like say, if you use the keto diet, you already know there are some side effects of this keto diet. So only focusing on one particular regimen is not important. That is what I can say. And yes, it is obviously there is a debate.
You mean to say that you should tailor this dietary regime according to the person you are addressing?
Always it is a person specific or patient centric approach. That is the main thing. Now in almost all disease, it is a patient specific or patient centric approach. That is the most important thing.
Jagdish, please unmute. Jagdish, please unmute.
Yes.
There are three types of morphism we learned. There are ectomorphic, endomorphic, and mesomorphic people. So in Ayurvedic, also in ancient knowledge, they said there are three prakrutis.
Yes.
So do you think, by your experience also, these dietary and lifestyle changes, and muscle is the most important endocrine organ of the body if you use it well? That is my question.
Yes, definitely. We have to base and we have to rely on some of the important principle of this Ayurveda. There is no doubt. It is one specific therapy is not specific for it. Means one guidelines or one thing is not, in short, one suit doesn't fit to everyone. That is what I can say. You have to rely on this thing.
Right. So Jagdish, your comments. Jagdish bhai.
No, is it possible to achieve ketogenic diet? Because to exhaust all the glucogen from liver and then start fat burning.
Yes.
How many days starving and with our carbohydrate-based vegetarian diet? How many patients you will be able to achieve ketogenic diet?
Really, sir, debatable issue, because what they are theory it is put out, but to implement such thing in our practice is almost impossible.
That's right. Yeah.
The answer is, Kiran bhai, liver has hardly 150 grams maximum of glucose, and that is exhausted in the hunger phase. So that is why the scientists are saying that feed small calorie, low diet, but intermittently, means but 8 hourly you should minimum do feeding.
Yes.
And what Jagdish bhai is saying, this metabolic switch is so difficult, because if you read the physiology of starvation, what Jagdish bhai says is that when you starve like Jains or somebody, your important smooth muscle, not only the striated muscle, but the smooth muscle of the gut, heart, kidney gets exhausted and burnt out, and then the fat burning starts. So the key is isometric anti-gravity muscle exercise.
Really, topic.
Kiran bhai, there is a question in the chat box by Dr. Sulim. He has two questions: how frequently to monitor HBAG and HGSAG, and is asking about treatment of hepatitis B virus infections.
To be monitored 6 monthly only, not before that.
Okay.
If you start the treatment, you have to monitor HB antigen and HBsAg surface antigen at 6 monthly. And if two consecutive HbA1c at 6 monthly interval is found to be positive, then there is no need to, because ultimately you consider that it is going to be a carrier for lifetime.
Right. See, treatment is a very big subject, no? HB.
Yes.
That cannot be discussed.
Only some of the important thing which I had told you, only algorithm. Because there are nearly more than 500 situations and you have to decide what to do and what to not to do. So it's really a big topic.
Any other comments or questions? So my question is, which is the next conference that you are attending, Kiran bhai?
I always attend this, basically this Epicon, because I think that Epicon is for all. Everything has been included if you attend it thoroughly, or if you attend whatever you want to know. And because ultimately whatever the speaker is there, it prepares fully in that particular topic. So if you thoroughly attend that particular topic, yes, definitely it's very important. So I always Epicon along with my 4 or 5 colleagues from Baroda. We always attend this Epicon right from 2003 onwards. I am attending regularly. And some of the international conference like International Diabetic Federation, that is what I am attending always.
I was looking forward to your further future talk. That's why I asked.
Try whatever is possible. I will attend and I will share our whatever knowledge we have gained from that.
Thank you so much. If there are no questions, I think we end the session here. Thank you all for joining. Next time we'll be having some a new topic like fetal medicine by Dr. Haley Shah.
Yes.
So we meet again next Saturday. Thank you.
Okay, waiting for that.
Thank you.
Thank you all seniors.